Good afternoon, everyone. I invite you all for this session. Though this is not named IC, it was submitted as IC only. So I invite our mentor, teacher, Dr. Mahesh Shanmugam sir, to be the master for this session, and I invite Dr. Raju to join us, and Dr. Jayaprakash, Dr. Krishnendu. Dr. Vishal will be joining us little late because he'll be like he has a presentation in another hall also, so he'll be joining us late. So though we have planned one 15 minutes session for us to enlighten with the words, Mahesh sir, he said he'll be taking his words after each presentation by us. So I would like to introduce you to this session, what I thought of when I submitted for this session. So like as we all know, some 20-25 years before, it used to be like rare entities and poor prognosis cases. But all these last 2 to 3 decades, having OCT handy and anti-VEGF injections and other injections and microincisional VR surgical techniques, we all know it has improved the perception. And even now, like whenever we attend any retina session, it's about how it presents, what is the difficulty in diagnosis, and how different is your approach for the surgery. But in the end, what the patient is getting, that particular thing is not clearly addressed in many of the publications and presentations. So I thought of this session for that reason. So to analyze the factors that can predict and what actually the publications say, what if you do this, what the patient is actually getting. So that we wanted to look at. As I mentioned, the perspective of general ophthalmologist is that the retinal disorders doesn't have good prognosis, and having a retinal disorder is a end of fruitful life. And the retinologists have this perception of not having encouraging results. I keep hearing people attending cataract surgery session saying that retina doesn't have prognosis. So this kind of perceptions are still there. So most of the presentations will look at how the injections work, how the one injection is different from the other, and like even for RVOs and DMEs and retinal detachments, what kind of different kind of surgical techniques that you approach, and regarding injections. And whenever you see iridomacular degenerations, inherited retinal disorders, like most of the times it is considered as brushed off like poor prognosis. But what are we addressing? Well, we have to address the patient's concerns. So what the patient has to expect from what we are treating. So any patient who walks into your clinic expects that his condition is cured, and he doesn't want to come back to you, and he wants to have least possible visits, and he expects that let him live his life. And the driving and other specific works in life are definitely compromised certain situations. So he wants all those things to be taken care of. So they don't understand. If you say my patients get 6/9, he doesn't understand what is 6/9. What matters for him is his life. So one should address that. So there are certain publications which looked at quality of life, like this particular paper, visual quality of life after macular hole surgery, outcome and predictive factors. So this VFU25 value is something which is considered to analyze the visual function quality. So this is a standardized one which they have used, and they found that preoperative visual acuity and OCT parameters, they do help, and there is definite improvement in visual quality of life in these patients after the macular hole closes and the vision improves. So this is one, though I could not get many VFQ because standardization is not there in most of the publications. This is one more, a large series where they have looked at many etiologies. They found that epiretinal membranes in their study gave the best quality of life scores after the surgery for epiretinal membranes. And certain studies, they found that epiretinal membranes not much of a difference, because that studies, they looked at cases where they were operated at better visual acuity. So those who are having poor visual acuity, they do definitely have a better quality of life after the surgery. So this particular paper enumerated many different etiologies and the visual quality of life. So we are going to look at the prognostic factors in terms of these, like what is in relation to the onset of symptoms or disease and disease parameters and associated pathologies, and what are the efficacy and limitations of treatments and what the complications that happen. So this is what we are going to have. And now I would like to invite Dr. Raju regarding to talk about rhegmatogenous retinal detachment and peripheral retinal lesions and how to prognosticate.
Thank you, Rama, for having me in this session. I'll be trying to briefly cover a vastly and extensive topic of both the peripheral retinal lesions.
Sorry, the other mic is not on. The other one.
Probably an extensive topic covering both peripheral retinal lesions and rhegmatogenous AD. So if you look at the peripheral retinal lesions, they are primarily classified as trophic tractional or trophic tractional, or sometimes as where they are from intraretinal, vitreoretinal, and chorioretinal degenerations. Based on this, you have these anatomical classifications also. But what really matters is when we are in our clinic is what is clinically benign and what is clinically significant, for which in those patients, I need to spend that extra time to talk to the patients. So this classification is what we would have in our mind mentally. So if you look at the clinically benign lesions, these are the microcystoid, snowflake, paving stone, drusen, honeycomb. So in these patients, we would usually not be worried too much because these are not likely to progress to any significant retinal issues in future. So you have the white without pressure, wherein it's mainly changes are there in the ellipsoid layer as far as the OCT has been done for the peripheral lesions in these patients. Again, microcystoid degeneration, again, it's also considered benign and no association with vitreous detachment or systemic conditions or for retinal holes in these cases. If you see the clinically significant lesions, two important questions that we should answer is, what is the risk of progression to a retinal detachment in these patients, or a risk of a retinal detachment per se, or should I treat this lesion to prevent it from having a retinal detachment? So if you look at some of the lesions which are significant, some rare ones I'll start with is the vitreoretinal tufts, which could be cystic or non-cystic. Here these appear as nodular elevations in the periphery, and these may have traction. Vitreoretinal tufts will have traction, and these may predispose to retinal tear or operculated hole or a detachment, especially when they have PVD, along with PVD. So when we see these patients along with the PVD, so then we should look carefully whether there is a tear in these type of lesions. And however, the risk of developing RD is less. It's less than 1% or 0.28% has been reported. Then other lesions are the meridional complex with a hole, the oral base. The oral base are small eye lines which are adjacent to the two dentate processes, and prognostically tears can be associated with oral base in 0.5% of these patients, and oral base again associated with the posterior vitreous detachment had at least one tear associated with the base. So whenever you find these, then we have to be careful and tell the patients that whenever they have the symptoms of PVD, they should visit us. Coming to the lattice, it could be typical or atypical, and atypical ones are the higher risk for retinal detachment. So whenever we have patients having a radial lattice or along the vessels, then we should ask these patients to come regularly and watch for any holes in these patients or tears. And it can also be seen in Strickler syndrome. However, the lifetime risk of RD in a patient with lattice is less than 1%, but we have to look at the other things like the vitreous adhesion at the borders. It plays an important role along with the retinal thinning, which can happen with time. Then you also can have tractional tears associated with lattice degeneration, and it is present in 1 to 2% of the retinal detachments. And detachments, when they have holes, they tend to occur slowly. Now, and when you compare with the lattice with tear, with holes, they tend to occur slowly, and they may have a pigmented demarcation, and they may happen in the inferior quadrants. So you have to look at the cumulative risk factors in these patients, like the axial myopia, then the age-related vitreous changes. Any intraocular surgery can substantially increase the risk. Then the tractional tears can lead to, are seen usually in patients more than 50 years old. Then if the patient has a RD or a RD with hole in one eye, the risk of detachment in the other eye is approximately up to 2 to 5%. So we need to educate the patients regarding the other eye RD also. Snail tag degenerations, you may find small holes, but these are not associated with RD, and prophylactic treatment is not necessary in these patients. Again, when it comes to typical retinoschisis, these are usually shallow, while reticular are usually bullous and can extend beyond the equator. And here again, if you have a break in the inner layer, there is no treatment required. And 16% of these patients can have holes in both the layers and can lead to retinal detachment. When it comes to retinal holes per se, these can be divided into operculated and atrophic holes. And in atrophic holes, only 19 patients had, out of 162, they had a subclinical detachment and which progressed to a retinal detachment. And of the 32 patients with operculated holes, no patients had a retinal detachment. So they say that you can observe these patients unless there is a PVD in these patients. But symptomatic, you need to treat them. Retinal dialysis also we need to treat. And Strickler syndrome, ensaklage with laser can be done. As far as the peripheral screening for refractory surgery patients are concerned, so this is the recommendation that is there in the IJO now. All symptomatic and asymptomatic horseshoe tears and operculated holes and lattice degeneration with holes and atrophic holes should be treated promptly. And the risk is most with phakic intraocular lenses, followed by phaco. This is the management as per the AO guidelines, and you can have a look at that. Most of the times, treatment is only required for symptomatic horseshoe tears and symptomatic dialysis. So we need to, important to tell the patients regarding the signs and symptoms of RD in these patients. When it comes to RD, prognosticating the cases, again, two important questions. Will this patient recover vision, or what will the single surgical success rate? So important factors to consider would be the age, comorbidities, and the history. We need to be sure that the patient is giving us the correct history. And if the patient is having associated myopia, the axial length more than 26 is associated with higher risk of surgical failure in these patients. I'll take 2 minutes more, please. Yeah. Again, with when it comes to retinal breaks, so it also depends on where is the break location, whether it is in the superior, inferior. But the studies shown that with PPV, in uncomplicated retinal detachments, breaks actually do not matter much. But we do see that patients who have got inferior breaks are at higher risk of problem developing a surgical failure, having a surgical failure. Again, you can have these multiple breaks in the same quadrant with PVR or GRT or large breaks like this. These patients may have a lesser chance of a surgical success. As far as macular involvement is concerned, this is most important for the vision, and 90% of the patients with macula on RD had a better vision compared to macula off vision, wherein only 50% of the eyes could achieve a final visual acuity of 6/15 or better. So if it is macula is detached for more than 1 week, the good visual acuity can rarely be achieved. Then when it comes to PVR, we can see that all these patients who got PVR have a very lesser risk of surgical success. And if the patient has PVR say grade C and above, then there's a chance of detachment, reattachment goes down very, very less. Again, the chronic RD, these patients may have a lesser chance of visual gain because of the pigmentation, even though the detachment is shallow. And associated features like presence of a complicated cataract surgery with dislocated lens may all complicate the matters. And the choroidal detachment, if it is there, the risk of failure is approximately 30 to 40% in these patients. Again, pediatric IDs are a different ball game, and they usually are the presentation, they have poor vision, and they gain lesser vision compared to the adults. So prognosticating RD, no matter how difficult it is to predict after surgery for retinal detachment, some form of predictive variables we need to have for patient counseling before surgery. Thank you.
Thank you, Dr. Raju. Actually, it's as you mentioned in the beginning, it's a long topic to cover, and we have many ifs and buts when we operate or when you encounter a case of retinal detachment, and even in peripheral lesions also. So I would like to hear from Sir regarding this particular topic, what we are supposed to look at a particular patient when we are, so after Dr. Raju's presentation. Sir, you are.
Sure. Mike? Yeah, it's fine. So we'll start with the prophylaxis of the lesions which Dr. Raju was mentioning about. Certain factors like that, the white of the pressure usually is not an issue, but then if the other eye has giant retinal tear, then white of the pressure is a risk factor. So if one eye has giant retinal tear, then I would treat the eye with white of the pressure with probably a barrage laser kind of a laser. So current recommendation is around 8 to 10 rows of laser around posterior to the areas of white of the pressure, decrease the risk of retinal detachment in the other eye. So if one eye has giant retinal tear. And microcystoid degeneration is usually not a pathologic lesion, but then that's the one which coalesces to cause a peripheral senile schisis. So that's something when you see schisis in one eye, we will find this areas of peripheral microcystoid degeneration in other areas also. Though I think like postmortem studies of 1,000 eyes showed that encysted oral bay is the risk for a retinal detachment or a retinal tear. I haven't seen one as yet. I have seen encysted oral bays, but I haven't seen one encysted oral bay causing a retinal detachment as yet. When lattice degeneration is concerned, mostly it's clear as to when we should treat. If the patient is asymptomatic, if there is family history, if the other eye has retinal detachment, definitely we would treat. Or if if there is a tear, definitely we would treat. If there is a hole associated with a little bit of fluid around it, whether we treat or not is always a question. But if it is a fluid which is around like 1 diameter, 2 diameter larger with the hole, I would treat it rather than not treat it. And then if the patient develops a detachment, then there is always we would have found it and we should still not treat it. So I would still treat it. So my dictum as far as lattice degeneration is concerned, whenever there is a doubt, treat rather than not treat. Better that like medico-legally you cover your back rather than not it, because the complications of treatment are extremely low. Unless the lattice degeneration is running across the horizontal meridians, where sometimes treating with laser photocoagulation can cause pupillary dilatation and accommodation difficulties for a short period of time. Most of the time, otherwise you can treat. Very rarely patients will complain of seeing those black lines because of the laser photocoagulation in the extreme periphery, and most of them do not complain. Another relative indication for me to treat lattice degeneration if the children are traveling abroad. So they go abroad for a study and they cannot access medical care immediately, then that would also be a relative indication for treatment. Refractive surgery is always an issue. Refractive surgery because I have had patients who have had a phakic intraocular lens implantation and within about 24 hours develop a detachment as well. So refractive surgery, I would err once again on the side of out of abundant caution and say that we'll treat these the weak areas before they undergo a refractive surgery. At least we would have done whatever has to be done. After that, they develop detachment. That's still we have done our best. Retinoschisis, outer layer breaks, usually I would treat them because if there's an outer layer break and an inner layer break develops, that can develop into a recombinant retinal detachment. So inner layer breaks need not be treated, can't be treated. So if it's an outer layer breaks, then I would treat them with laser photocoagulation so that it doesn't progress to detachment. And I have seen a HST as an outer layer break also. How that happened, I don't know, but then I have seen a HST as well. As far as retinal detachment is concerned, all of us are familiar. The duration of the detachment, degree of PVR, and macula on or off are the main factors as far as the vision is concerned. As far as the anatomical success is concerned, the size of the break, and if there is associated PVR and age of the patient are the ones which are as far as the anatomical success are concerned. And certain things I would want all of us to keep in mind. So if you see a child with a retinal detachment and a giant retinal tear, then we need to be particularly careful because these are the ones who may be syndromic. So particularly ask to see if the child has had a cleft lip surgery. If it has had a cleft lip surgery, there's a very high chance that this child has Stickler syndrome. Best would be not to go inside the eye if it is possible, not to do vitrectomy in these eyes if it is possible. If it is absolutely not possible, then of course we have to do abundant caution and take these patients up for vitrectomy. CD with RD, yes, vitrectomy has better anatomical prognosis as compared to scleral buckling. That's what one of our studies when we did what we did in Shankarnedala showed. We can treat them with steroids, but then steroids is not the only treatment. But then you do steroids, then drain the choroidal detachment, then doing a vitrectomy removes all the inflammatory mediators from inside the vitreous cavity, which increases the chances of a surgical success. Another concept is what Dr. Rajiv Muni has been popularizing about metamorphopsia post retinal detachment surgery. That is like a misalignment of the photoreceptors. So that he presumes, he says that at least his paper says that it's much worse if you were to do a vitrectomy and forcibly reattach the retina on the table as compared to a pneumatic retinopexy. So my counter would be, yes, in a given situation, you still have to do a vitrectomy, but then leave behind a little bit of fluid in the posterior pole. So let's not drain it completely dry. So leave the macula detached and use the tamponade with gas or oil, whatever it is, and allow the posterior pole to reattach by itself, then the metamorphopsia is likely to come down. So that would be my comments as far as the prognostication for Dr. Raju's talk is concerned. Wonderful talk covering a lot of aspects. I'm sure all of you can add up to it, yes.
Anyone has anything to ask or discuss? Sir, I would like to ask regarding the quality of life post-retinal detachment surgery and the vision perception by the patient post-macular surgery, either a macular hole or a peripheral membrane, and post-retinal detachment, total retinal detachment. So how does it changes the life of a patient, if at all, even after having a good surgery success? Does it matter? Because in the immediately post-operative period with oil also, people keep saying I'm unable to drive properly because I can't perceive something coming from this side, and there are certain particular points where they are very much worried about. So regarding the quality of life after the surgery, do you think good success of the surgery is giving a normal life, or does it anyway change the quality of life of a patient?
Almost most of them do get back to a normal life. It's not as though unless it's a long-standing retinal detachment with PVR, and that those are the patients who have probably got about 660, 636 vision are the ones who may be affected. But otherwise, with a young patient with a fresh RD, with no PVR, they get back a reasonably good vision, and it's not as though we cannot expect them to get back to normal life within the next 3 or 4 months. The vision continues to improve over the next year and a half. So they go on to lead a normal life. I wouldn't think that they go on to have an abnormal life. I have had patients who are doctors, who have had surgeons, who had one eye retinal detachment. They've gone back to doing their surgeries. So it's not as though it's so difficult. Certain aspects are there. Of course, if we do a scleral buckling, there may be an anisometropia. And of course, if you do vitrectomy and oil, there can be anisometropia, which would have to be taken care of. That's something which I tell them. So I prefer buckle most of the time if it is possible, and only if not possible, then I go for a vitrectomy. So though the buckle can give rise to an anisometropy because of the power changes, but actually the tamponade gives rise to much more anisometropia in the long run also, because they develop a cataract and these patients are myopes in one eye, and if you do a cataract surgery, then again results in a anisometropia. So wherever it's possible, I prefer buccal surgery. Yes, Manisha.
So many a times post-RD surgery, the anatomical picture looks very good, but the visual improvement is not so great, and you get a re-refraction done, still you are not able to really explain why the visual recovery has not been so great. So what are the things you would rule out in such a situation, sir?
Again, preoperatively, the duration of the surgery, duration of the this RD which has been there, and if there are any associated problems. For instance, if the patient is an anisometropic even before, they may have a component of amblyopia which was there. Second is, of course, if there was something which went wrong during the surgery. So if the intraocular pressure was high, or if there was any iatrogenic optic nerve damage, or if there was any additives which were used in the fluid or in the subconjunctival space which went to the vitreous cavity and caused another additional toxicity to the retina. So those are things which I would look at. Despite all this, yes, there is a small segment of people who continue to have the issues. One of the things we can do is to do this visual stimulation or exercises. So that's something which can be considered. So we have had patients who have not improved, and just visual stimulation, even if they are adults, so that seems to improve them. So ask them for a particular type of exercises which they do, that seems to improve your vision over the next few months or so.
And do you prognosticate your patients with silicone oil that after the removal of oil, some of these patients do show a drop of vision, sir?
Yes, I don't tell them that most of the time. I tell them the risk of a recurrent retinal detachment, which can be 1 in 10. But most of the time, because this is not a very common phenomenon, yeah, it's extremely difficult to explain to them. It's extremely difficult to explain to them after that happens. But before that also, it's very difficult. So I don't tell them that like your vision may go down after the surgery.
Now I request Dr. Jayaprakash to deliver the lecture about inherited retinal disorders prognostication.
Good afternoon, everyone. I'll be talking on predicting long-term prognosis in hereditary retinal disorders at presentation. So inherited retinal disorders are a large group of diverse disorders. There are more than 300 genetic mutations identified so far, and it leads to retinal degeneration, leading to severe visual impairment and blindness. And it's quite common, 1 in 3,000. It's very heterogeneous, and there is a genotype-phenotype mismatch. So when you encounter a patient, the patient has a lot of questions. Is it a hereditary disorder? Is it treatable? Will it progress? What are the chances of further visual loss? Can we halt the progression? What will be the final outcome? Do I need aids, and what aids do I need? How to plan my education, career? Can I drive? And will it affect my offspring or sibling? So these questions have to be answered, and that's why we are looking at this. So the first and foremost is to diagnose the inherited retinal disorder. So early and accurate diagnosis is very important. So we do it by a detailed ocular, medical, and family history, clinical examination, multimodal ocular imaging, systemic investigations, and molecular testing. Once the diagnosis is made, then we need a interdisciplinary approach, not only by the ophthalmologist, but by other specialists, to cater to the biological, psychological, and sociological needs of the patient. So let's look at the crystal ball, see what are the prognostic factors. The age of onset, if it's a younger age of onset, then the prognosis is poor. Poorer vision at presentation leads to poorer long-term prognosis. Among the inheritance pattern, X-linked RP has got a poorer prognosis, whereas autosomal dominant has got a slightly better prognosis. Syndromic inherited disorders have poor prognosis, not only for vision, but for the life also, because they have a lot of systemic associations. One important thing is to differentiate between a progressive or a stationary inherited retinal disorder, because progressive, as you all know, has got a very good prognosis, whereas stationary have little good prognosis. So you differentiate based on the history. The patient can tell that the condition is staying the same or it's worsening. Clinical examination, yes, and investigations, I'll cover that subsequently. The fundus findings also give us a clue. We have advanced findings and macular involvement. The long-term prognosis is poorer. Visual fields are also very important, and those with advanced field loss and macular involvement at presentation have very poor prognosis. ERG is very important. For example, this patient had 6/9 and 6 vision with the retinitis pigmentosa. You want to know how advanced, you do an ERG and is showing total loss of responses. But still, the patient does have visual potential. There's a small central peak on the multifocal ERG. In another patient in whom the central peak is also lost. So ERG can help in prognosticate. It can help in differentiating stationary or progressive. For example, there's an 18-year-old girl who came with nyctalopia with multiple flecks over the fundus. And the dark adapted full field ERG showed reduced scotopic responses. But on prolonged dark adaptation after 4 hours, it shows normalization of the ERG. So it's a stationary disease, fundus albipunctatus. Whereas in another patient with a similar finding, the ERG did not improve even after dark adaptation, and the patient had retinitis punctata albicans, so it is a progressive disease. Clinically also there are some findings that you have disc pallor, arterial attenuation, which can give a clue about whether it is stationary or progressive. ERG tells whether it is rod related or cone which is predominant. In this patient, it was the cones which are more affected. So in cone rod dystrophy, the poor central vision, so the visual outcome in the long term will be affected much earlier. Again, this patient who came with bullseye maculopathy, whether it's cone dystrophy or Stargardt's without flex, ERG can help us to diagnose, because at least in the early stages, Stargardt's without flex will have a normal ERG, whereas cone dystrophy will have a reduced response in the photopic. The other clues like loss of color vision and photophobia in a cone dystrophy. So to sum up, ERG abnormalities occur in the early stages before the symptoms and fundus abnormalities happen. It differentiates the different types of the disorders. It can diagnose atypical forms and is also quantitative. So if you're following up, you can tell the patient how the progression is going to be. In patients who have poor fixation, you can do a full field stimulus threshold, which is again coming up now because of gene therapy coming up to tell when to give the treatment. Multifocal ERG can be done in patients in which ERG is not recordable or in whom the retina appears clinically normal. So ERG is both prognostic in both the early and advanced stages. Coming to OCT, in the inherited retinal disorders, the interdigitation zone is the first which is affected, followed by the ellipsoid zone, the external limiting membrane, and finally the outer nuclear layer. So basically the photoreceptors are affected. So this is a patient who had retinitis pigmentosa with macular sparing. So you can see that the eyes interdigitation zone is spared in the central area, and the ellipsoid zone little larger area, and the external limiting membrane to a much wider area. So there are a lot of studies which looked at this. Both ellipsoid zone integrity and length, both are very important in prognosticating, and those with EZ loss at presentations have a poorer long-term prognosis. So there is a grading in achromatopsia based on the OCT. So you can see progressively how the ellipsoid zone and the other outer retinal layers are lost on the OCT. Hyperreflective foci in the outer retina, if present at presentation, again has a poorer prognosis. There are some choroidal parameters like thin choroid and reduced choroidal vascular index, which indicate poorer prognosis. Even the pattern of the choroidal vessels, like a normal appearing choroidal vessels, has a good prognosis, whereas when the hallus atlas layers are reduced, the prognosis is poorer, and those who have choroidal caverns, there is even further worse prognosis. There are other concurrent problems in inherited disorders like ERM, macular hole, cystoid macular edema, and when these are present, again the prognosis is poorer. OCTA also has been used to look at capillary rarefaction and FAZ enlargement, and if it is present, indicates a poorer prognosis. Coming to autofluorescence, in about 50% of RP patients, we have hyperautofluorescent ring, which is known as Robson's ring, and the size of the ring is important. If it's a smaller ring, then the prognosis is again poor. So the different patterns described. If there is no ring, then there is usually no progression. If there is a ring, it indicates that there is a progression going on. Whereas in the advanced stage, there is either increased or abnormal fundus autofluorescence. Quantitative autofluorescence also coming up in a big way, and it is actually a surrogative marker for predictive genetic testing. And in this patient of Stargardt's disease, there has been an increase in the quantitative autofluorescence, which then reduces with the onset of the RP atrophy. Wide field autofluorescence is now available, and it corresponds very well to the visual fields. And if there is macular involvement, then again the prognosis is poorer. Wide field autofluorescence, the area of the hypoautofluorescence increases with age and disease duration, and more hypo areas means the prognosis is poorer. There are some biochemical tests, like in gyrate atrophy, we can do the plasma ornithine levels, and in beta lipoproteinemia, lipid profile can be done. And in these conditions, early detection, diet restriction, and supplementation, we can actually change the prognosis of the patient. Genetic testing, yes, we have now gone on to whole genome sequencing. I'll take about a minute more. And there are a lot of clinical trials, and we know that Luxturna is now available for therapy. Last, artificial intelligence is now being used to predict prognosis. It is based on fundus images, fundus autofluorescence, OCT, adaptive optics, pupillometer, and different combinations of these. So various algorithms and models have been described. And the machine, once it learns, it kind of gives the genetic diagnosis and also the prognosis for the patient. There are some limitations. To summarize, timely, accurate diagnosis is very important. Appropriate interdisciplinary management and the correct prognostication is important for the overall development, lifelong visual function, quality of life of patients with the intellectual disorders. And artificial intelligence is going to be the future in prediction. Thank you. I would like to take this opportunity to invite you all to our 6th Retina Summit and 8th IROP annual meeting in July.
Thank you, Dr. Jayaprakash.
Thank you, sir.
Sir, your words.
Well, I usually hate to see these patients. I usually send them off to another one, and Dr. Jayaprakash did a great job of putting everything together. It was wonderfully placed. So if I was forced to counsel them, I would try to remain positive, though it may not look positive, the outlook, but then I don't tell them that, like, it's extremely difficult to say that, like, oh, you're going to lose vision in the next 3 years, 4 years. So I usually tell them, don't lie to them, but at the same time try to put a positive spin. So I may or may not be proven right, but I've been telling that, like, in the next 5 years you'll get a genetic gene therapy for the last 20 years. So it's not often that patient comes back and tells you, like, 5 years back you told me gene therapy will come, where is it? So, but like you give them a like positive outlook, saying that, like, things are looking promising as compared to what was 15 years back. 15 years back there's no hope. Now there seems to be hope. Some forms of RP has a treatment, so I think that, like, probably in the next 5 years, 10 years, it can come. 5 years later, if they come, I'll tell them, yeah, it has come in USA, in India, probably another 5 years it will happen. But then, like, you give them the hope, so don't let them lose hope. Of course, like, all the prognostic factors he has put across very, very beautifully. And other thing I look at is, like, look for treatable causes. Yes. So if there is a cystoid macular edema, if there's a schisis, or if there's an ERM, or there's a macular hole, then there is some treatment you can do to improve the vision. So you can use dorzolamide or systemic astazolamide, epiretinal membrane you can remove, macular hole you can close, and there's cataract. Cataract, once again, many of them have a posterior polar cataract, so you ask them if in case they have glare in the night, so cataract surgery can help. But of course, we need to be careful in telling them what it is. So the treatable causes I would look for and treat them. And if there's absolutely no possibility, still I tell them, like, okay, let's see if there can be a cortical implant, there can be something. So you always give them a little hope. And check the offspring for genetic thing is a little doubtful. Nowadays I've been telling them to have a genetic testing for themselves, telling them that, like, let's have things in place. So subsequently later on, if gene therapy comes, maybe if you are eligible, then you can go ahead with the treatment. So I do have a gene therapy done, and that helps us to kind of precisely diagnose it. So even recently we had a patient where I was wondering if it was autoimmune retinopathy or heredoretinal degeneration. So we screened for autoimmune retinopathy, which is negative, and then heredoretinal degeneration. Genetic testing was done, and it did show something like that. Offspring, many times they ask, like, do we screen our children? I tell them best is to leave it alone, because, like, when you don't have a treatment, you screen and tell, yes, your son has got RP, adds another layer of additional stress to them. So best is to just, because when you have a treatment, it's fine. But when you don't have a treatment, then what is the problem? What is the thing? So I don't actively push them to have testing of their offspring in contrast to what I do for retinoblastoma. So that's how I go about it. I don't think I can add anything more to what Dr. Jayaprakash has covered.
Thank you, sir. Anyone has any question? Now, yeah.
It's to Dr. Jayaprakash, I hope.
So to you. Okay. Jayaprakash, if a child comes, it's okay about the adult counseling. They have accepted the fact because they have accepted the fact for so many years now. But sometimes in the OPD, the first case is a child, and they don't know the diagnosis, and it's it's their first visit because the teacher has said that the pupil is not paying attention, and you discover head macular degeneration, and it's not very uncommon. So how do you counsel these parents? Because in India, we don't have a support program for these kids, not enough quality blind school programs also. So what is your approach in these cases? Specifically a child who has been diagnosed for the first time and there is no acceptance when you tell them, because they are not ready to accept that something is wrong with their kid.
In our LVA clinic, we have they do the counseling part also, so that takes care of some of them. I counsel them in the clinic, tell them, but some of the part of the counseling happens in the LVA clinic. They have to accept, so.
Yeah.
But only thing is that we can tell them that it is not that end of life. They have support, even in India, though program is not there like for a particular diagnosis. We do have support clinics and supporting organizations. So we can always guide them for that. If it is very severe or if it is in the early stages, we can always tell them how to plan the life regarding the profession and other things.
The thing is to give them some time. Unless the child is absolutely blind, then give them time. We don't know how it will be. It may turn out to be, it may be slowly progressive. So give them some time, because I come across this ROP stage 5s as well as retinoblastomas. Retinoblastoma, I tell them upfront, because if they don't do the proper care in proper time, then it's going to be risky to the life. So, but otherwise I tell them, yeah, there is a possibility. Let's see, it depends on how it goes. Because we can never predict. Some children may still see. So I kind of beat around the bush the initial time.
That is not the end of the road, but at the same time we have to caution them about what not to do.
Correct. But subsequent visits, you tell them, okay, yeah, correct, maybe it's progressing slowly. So bring out the news bit by bit, I think.
Because certain things like driving and all, I ask them to avoid.
So talking of ROP, sometimes you accidentally say ki this is the first time you are having a ROP screening. When you see a stage 5, so they directly blame the pediatrician, and then your colleagues are in a soup. After that, they go back and say
correct. That happens not from the consultant point of view. It happens from the fellow's point of view, or when they are taking the history, it comes out inadvertently. That you would have to sensitize them probably.
Now, Dr. Vishal will prognosticate the largest topic, the diabetic retinopathy and RVOs.
So thank you, Rama, for giving me this topic. As Rama said, it's a huge topic. I'll just cover all, as I talk to him, all the proven, prognosticating factors and not the hypothetical ones which are still in controversy. So my topic is predicting long-term prognosis in diabetic retinopathy and RVOs at presentation. So, it involves, in both these diseases, it involves various factors apart from the ocular factors, as we know, as opposed to AMD, like type of disease, stage of presentation, whether it's, a simple NPDR, even if the patient is euglycemic, or a very late stage RVO with neovascularization. The areas of involvement, of course, if there's a peripheral involvement with a very good vision, and if the patient has a macular ischemia, or the number of prolapse and the extent of prolapse. The treatment efficacy, you're going in with anti-VEGF, but the patient is responding to anti-VEGF, or you need to switch and you are taking it lightly. Patient systemic health, of course, you have to be in consultation with your physician or endocrinologist, and patient compliance with treatment is a very important factor, because these are long-term treatments, not a one single shot of anti-VEGF or a one single sitting of laser. So how compliant the patient is with the follow-ups. Lifestyle modification, as hard as we might try, lifestyle modifications are very difficult to modify. Easily said than done. And the complications, of course, associated with all these post-laser hemorrhages, post-injection macular holes, these are all. And finally, ocular comorbidity, whether the patient, along with the diabetic retinopathy, NRVO has glaucoma or other comorbid conditions. So, collaborative care with physician and endocrinologist is essential for optimizing patient care and improving prognosis. And the systemic management includes glycemic control, the hypertension management, lipid-lowering therapy, and cardiovascular risk reduction. Of course, this is a very large topic, and I will be concentrating on the factors in the eye. And for that, there are diagnostic tools now, excellent diagnostic tools, which aid in assessing disease progression. And the most commonly used, as we all know, is OCT and fundus photography, and now the ultra-wide field fundus photography, OCT angiography, visual field testing, and deep machine learning. So the bottom line is objective analysis in any disease, along with multimodal imaging in eye, is the future now. So the current imaging modalities play an important role in deciding the treatment protocol, as well as prognosticating the outcome. And we have now various imaging biomarkers which provide the assessment of the health of the retina, and a near histological assessment of the capillary density and FAZ. Coming to the OCT, spectral domain OCT and SSOT are the most advanced technology available to evaluate the macular health at present, which is very important in these two conditions. So coming to the biomarkers, many of these biomarkers are overlapping in both the diseases, diabetic retinopathy as well as RVO. The first and the most common thing we see when a diabetic patient with macular edema comes is retinal thickness, of course, the CST, central subfield thickness, which can easily be monitored in the OCT and measured. But despite that, despite the resolution of the DME and the amount of DME, the gain in vision might be suboptimal. And it might be, after the treatment, it might decrease also because of the macular atrophy, because of long-standing edema and resulting damage to the photoreceptor. So therefore, central subfield thickness is not a good prognostic or predictive marker of final visual outcome. The other things which we have to look along with macular edema is the duration of the edema, the pattern of the edema, the extent of the retinal involvement, the layers involved, and the differential involvement of inner versus outer retinal tissue, and the status of the photoreceptor. Coming to the second most common thing which we see in a diabetic macular edema is cystoid spaces. So size and location are very relevant. Size, of course, have been categorized as less than 100 and 100 to 200 and more than 200, classifying as a giant cyst. And the area of the cyst also. So a parafoveal cyst will not affect the vision much and is a good prognostic sign. And a last cyst at the fovea is a poor prognostic sign, especially if it involves both the inner and the outer retinal layers. And of course, many studies are there with correlating the size of the cyst with the extent and magnitude of macular ischemia. Another very common OCT biomarker we nowadays use and has been proven as a poor prognostic criteria is DRIL, that is a disorganization of retinal layers, and it is inability to distinguish between the inner layers, the ganglion cell layer, inner plexiform and inner nuclear, from the outer plexiform layers. This is measured in the central 1 mm zone, and more than 50% involvement of the central 1 mm zone is defined as DRIL. So it has to be proven as a reliable biomarker for the presentation for prognosis, long-term prognosis of visual acuity in DME. And of course, many studies have correlated its association with a non-perfusion, size of the FAZ, and increased severity of diabetic retinopathy as well as retinal vein occlusion. Hyperreflective dots, by definition, these are less than 30 microns, and they have absence of backshooting, so you have to differentiate between them and hard exudates. And more or less, the reflectivity is similar to the nerve fiber layer. And many studies have said that they are inflammatory markers, and also they respond very well with steroids as compared to anti-VEGF, but also they are associated with early recurrence. So if there are many HRFs, hyperreflective retinal foci, the patient should be frequently followed, because the recurrent edema chances are more in patients having HRF associated with macular edema. Hard exudates, these are similar to HRF, but larger in size. And of course, the area of involvement, the foveal involvement, implies poor prognosis. Integrity of ALM and EZ is also very important. Visual acuity has been shown to have a positive correlation with the survival of both these layers. Of course, refractory edema, TPH, and the taut posterior halide is a very important factor. Surgery is the only thing. It might resolve the foveal contour, but it might not correlate to the visual outcome. There are many other biomarkers. Because of the paucity of time, I'll skip to the next modality, that is FFA, and it has been considered to be the gold standard in studying the retinal vasculature. And now we are using mostly ultra-wide field imaging, and an extended field of view is crucial in these diseases for the diagnosis and the treatment and prognosticating the disease by imaging the peripheral retinal ischemia. And patients with extensive ischemia should be followed up more closely So in this case, if the patient's presentation is florid, the patient has 6'9" or 6'6" vision because the macula looks okay, but there's a florid, proliferations. And I would counsel and even take a consent before lasering the patient because there's a high chance of vitreous hemorrhage post-laser. In this case, again, there are no, massive proliferations, but the ischemia is involving the foveal center. So the prognosis is generally bad, even if the edema resolves. And in this case, the prognosis is very good because the FAZ looks okay, and not a large amount of proliferation is there in the periphery. Skip this. This patient, again, with a 6'12", 6'9" vision, he was a one-eyed patient. The patient was doing well lasered, and I would not intervene, and it's a fair prognosis. Of course, I will, closely follow up this patient and operate only if it involves the foveal center, as opposed to this patient, which was given an anti-VEGF for a macular edema. Supposedly, it was a tractional detachment, and now it has caused a combined detachment, and the prognosis is significantly less than the patient I previously mentioned. Coming to the last OCT angiography, it provides detailed information of the retinal-choroidal macrovasculature and can separately analyze each of the three capillary plexes. The caveats are long acquisition time, artifacts, and limited field of view. We all know it beautifully, tells you about the FAZ and the mechanisms and the involvement of the fovea. So to conclude, in the realm of retinal vasculopathies, whether it is diabetic retinopathy or RVO, every leak and every blockage tells you something about the systemic imbalance, and in the intricate network of retinal vasculature, abnormal systemic health is indicated. And apart from clinical examinations and advances, the advancement in multimodal imaging has come a long way in predicting and prognosticating the course of disease in the long-term management of these diseases and modifying the treatment in between. Thank you so much.
Thank you, Dr. Vishal. Beautiful wide field images. And for those who don't have that wide field imaging, I don't think we can prognosticate better. So, sir, your words.
As far as the diabetic macular edema is concerned, if there is edema, we treat. So we don't tell the patient like how much he's going to improve because we cannot prognosticate that. But then it helps us decide when to stop or continue the treatment. So that's what the prognostic factors help us in doing. So if there is drill and if there is chronic cystoid spaces, then we tell them we'll give an injection and see what happens. And if in case the patient's vision does not improve beyond a line or two, whether to continue the treatment or not is what the prognostic factors helps us. As far as the patient is concerned, we tell them yes, vision will improve. How much it will improve, we don't know. So most of the time, with the subretinal fluid, they will improve quite significantly, but with the intraretinal fluid, long-standing cystoid spaces, they may not improve much, but they will improve. So it just depends on whether they respond to the injection or not. So I would still try to treat them and then see. But we know mentally that when do we stop the treatment or continue the treatment is what the prognostic factors will tell us. Another factor is the hard exudate clump at the macula. So these are things which you know that the patient is not going to improve much because even if the hard exudates go away, there can be an atrophy. That help us decide what kind of agent to be used. So most often we would prefer probably steroids, but though the anti-VEGFs have also been shown to make the hard exudates go away, but at a little later time duration as compared to the steroids. Presence of vitreomacular traction, Dr. Vishal did show a taut posterior hyaloid which is pulling it up. Those we would definitely operate, but there was a focal attachment which is just pulling up only the central fovea. I would probably not operate at the initial instance, inject and see. Sometimes despite the obvious looking VMT, the macular edema goes away. If it recurs much often, or sometimes the PVD may occur or because of the swelling going down as well. So in that situation, once again, that will help me prognosticate whether the patient will need a surgery or not. RVO, one thing I am still unable to prognosticate is the number of injections. I tell them that RVO patients may need lesser injections as compared to AMD, but sometimes they keep needing injections over the next many years. So 5 years, 6 years also some of them continue to need injections, so I am unable to prognosticate. So I usually tell them 5 to 8 injections the first year. Second year, third year, I tell them lesser number of injections, but it's may not work all the time. One other thing which I look for in younger patients with vein occlusions, particularly central retinal vein occlusion, they may have a temporary or a partial central retinal artery occlusion. So we look for to see if in case there is whitening of the retina. So some of these patients have a perivasculitis, so that can cause this. So in that situation, they may present with a significantly poorer vision, in which case they actually have a very good prognosis also. And younger patient, I would usually treat them with oral steroids. So that seems to abort this optic nerve associated inflammation and the perivasculitis, and some of them may not progress as well. So I would usually treat them with steroids. And presence or absence of edema when they present initially is something which makes me decide how they will prognosticate, how they will progress. If there's no edema, but the patient has some vague symptoms and you know you have seen a central retinal vein occlusion, then I would probably call the patient about a week or two later. The moment some edema happens, then I will start injecting even if the visual acuity is 6.6, because then sometimes we are able to reverse the disease in these patients. CRVO, of course, the other prognostic factors which we always look at are the presence or occurrence of a relative afferent pupillary defect, ERG, as well as gonioscopy to see neovascularization. No, I don't go by the numbers at all. There are two situations what you're talking about. This is the initial attack of the disease and the patient has come with some cystoid spaces, but the visual acuity is still 6.6. If in that situation, if it's the initial attack of the disease and patient has come immediately after the occurrence of the disease, and even if there is mild cystoid space and visual acuity 6.6, I would treat the patient, particularly if young. As I mentioned, these are the patients I treat them with oral steroids as well, to see if you are able to stop the disease. Sometimes you are able to stop the disease. They do not progress. There's a reversal of the disease and the vein occlusion resolves and then it doesn't progress. But on the other hand, the patient has been having the symptoms for some time and then comes there with some cystoid spaces and probably some vision like 6.9, 6.12, but still it is not as thick as what it was. I would probably initially inject and see if the edema goes away associated with improvement in vision. If there is improvement in vision, then I'll probably follow them up closely to see if they need additional injections. But after the initial injection, they don't see any improvement visually, but the edema goes away, then I know that this patient has been having a chronic edema, and then I'll leave it. So, and I usually individualize the treatment for these situations. Yeah. Some of these patients, if you operate early enough, that the proliferation actually is easier to peel as compared to allowing them to become fibrous and then get attached to drag the retina down. But on the other hand, if the patient has 6.6 vision and then if you operate, then there's a probability of losing vision because of retinal breaks and bleeding as well. So I usually don't operate if in case like there's no TRD or if there's no combined retinal detachment and the vision is still good, to see if they progress. So I would go ahead with the laser photocoagulation in the extreme periphery, leaving about 2 disc diameters of space from the neovascular proliferation beyond. So 2 disc diameters of space, you leave it and then go ahead with the laser photocoagulation. Telling them that like despite, not that because of the laser photocoagulation bleeding happens. What we tell them is despite the laser photocoagulation, bleeding can happen is what you tell them. Despite the laser photocoagulation, detachment can happen. But if you don't undergo laser photocoagulation, you're going to become blind. So that's what I tell them. And follow them up and see at the earliest sign of traction, and then like we find that like probably 1 or 2 lines decrease in vision, then we can jump in and do surgery. These are the where you can give an anti-VEGF and within about 2 to 3 days you can do the surgery. Advantages like in these patients, actually the proliferation peels off easily. So the earlier you operate, younger proliferation actually peels off easily. But on the other hand, they can have increased risk of bleeding during the surgery. So immediate post-operatively, they may have recurrent vitreous hemorrhage, so it takes a little longer for them to recover vision. So we have to counsel them. So tomorrow when I remove the patch, you're not going to see much. So it's going to take, your vision is going to be much worse than what it is before the surgery. It may take about a month for you to get back the surgery. So I counsel them that way and then go ahead to the surgery. So yes, it's a sometimes very difficult situation, but very close follow-up under graded laser photocoagulation is what I would do.
Now I request Dr. Krishnendu to talk about prognosticating macular disorders, medical macular disorders.
Yeah, thanks Dr. JVN for giving me the opportunity to speak in this podium in front of sir. So always whenever you see patient, the patient always asks what is the outcome, what will be the outcome if you treat. So I am coming one by one. So first my topic of discussion is AMD is a vast topic till I need to finish it first. So whenever the patient comes either with PD or SRF in advanced stage or early stage. So if the patient comes with this PD and kind of hyperreflective spots, then we have to be very cautious because otherwise the patient will develop CNVM in future or geographical atrophy in future. So PD by say we have to keep them under follow-up. And PD height also important. The patient is chronic follow-up, only the PD, there is no SRF, nothing, no CME. The patient can be followed up. If there is increase in height, the patient can have CNVM later. So in these cases, we need to do OCT angiography in order to visualize the membrane if it is there. But don't have to treat all membrane unless they are presented with the structural B scan. And intraretinal fluid is more ominous. Intraretinal fluid are very difficult to treat. Here the patient needs aggressive treatment than the only subretinal fluid. And the subretinal hyperreflective membrane also a poor prognostic indicator. The patient presenting late and there is a thick subretinal hyperreflective material which is very difficult to go away. Even if we treat on and on, it keep on persisting. The RAP lesion, if the patient presents with the RAP lesion, very poor prognosis gets signed. If you can see, there is a edema, there is a SRF, there is a PED, everything is there. So the patient, even if we treat with PDT, repeated injection, the patient outcome will be less. Patient can present with scar. So even if you see the scar, if it is involving the fovea and parafoveal, it can prognosticate the disease. If it is parafoveal, it's a good prognosis than the foveal scar. Degenerative cyst, more important to differentiate between the cystoid edema and the outer retinal tubule which is there. So in the patient presented with the outer retinal tubule with the edema, definitely will not going to do well with the injection. And the large peak PD with the SRF, this patient often we jump to give injection and patient can land up having a rip. So this is a poor prognostic case with a large PD. The geographical atrophy, we can see the prognosticate. If there is away from the fovea, then it's good, but if it can involve the foveal region later on in future. So patient can be followed up closely and cautious that this might progress, not to frighten them, but just to let them know. PCV, large hemorrhage, is a poor prognostic indicator. Sometimes they present with peripheral polyp, which can be lasered after pneumatic displacement. This kind of large retinal, subretinal bleed, very difficult to treat. They might need surgical intervention. And sometimes pneumatic dispensations often work. Now, another type of disease, there's a CSCR. Now it is being classified as a simple and complex. Before it was acute and chronic. Now, this definition recently came into the picture. It's mostly defined by the fundus autofluorescence. That is the 2 disc diameter of RP changes. If it is less, it's simple. It is more than it's complex. The bad prognosis when the persistent CSCR is there, subretinal fluid persisted more than 6 months even after you do laser, outer retinal atrophy, and if the patient presence of bullous RD, RP dip, gives a poor prognostic indicator. Like this way, this is large cystic space. It's a chronic CSCR, it's a complex CSCR, large cystic space, this is a cystoid degeneration, is not going to do well. Next is the outer retinal atrophy. We treat the patient with CSCR that develop outer retinal atrophy. It is again is not going to do well. RP changes. Here the fundus picture, even the red free picture doesn't show well, but if you see the autofluorescence, the area of RP atrophy is huge. So this is the complex CSCR. Again, you can see there's a multiple leak CSCR multiple patient is on steroid, we have to stop steroid. And the ICG gives you better indication that how far the choroidal vessels are. This is a multifocal leak CSCR. Here we can, there's a large PD, you can see the pooling of dye here. We have done the laser, and what happened after doing the laser? It ripped. So large peak PD is a chance we can, even after doing laser, it can rip. And bullous detachment, what I have explained. Now coming to MACTEL. MACTEL, though it's very poor, but even sometimes we can prognosticate to see there is a fluorescent angiography showing there's a fuzzy leakage, and the OCT showing there's some clumping in the outer retinal layers. So there's an indication, there's a hemorrhage exudation indication of CNVM. Here you can see the arterial and venous anastomosis here, and there is a clumping of the outer retinal layers. So indication of CNVM going on. This is a publication by Ramesh, which shows there is a pre-proliferative stage of MACTEL, which can be detected by the doing OCTA, where you can see the DCP, there's a crowding of the blood vessel in deep capillary plexus. It is an indication that patient can develop CNVM in future. Now last topic is the myopic tractional maculopathy, though the cause is little unknown. There's a lot of reason behind it. It can be due to rigidity of the ILM or retinal vascular traction. The problem is often we don't have to treat, but if the patient develops SRF, subfoveal SRF, then we have to treat by doing ILM peeling, sometimes macular buccal if it's a deep-seated eye. Generally they do resolve by their own. If it doesn't resolve, if there is a foveal detachment, if there is a retinal detachment, full thickness macular hole, then we have to intervene by doing vitrectomy or macular buccal or together. There is a case of myopic maculopathy with a foveal schisis or subretinal fluid, and even if we treat, the subretinal fluid tend to persist for long period of time. We have to wait, and sometimes they develop macular hole. See, this is a case of macular hole with a subfoveal SRF, preoperative picture, and even if we settle the retina, there is a thinning of foveal layer. So the prognostication is a poor outcome. Now last topic is the blunt trauma. The blunt trauma, always the OCT is helpful. If there is a no change, the only undulation of the external, EZ zone, there is a good prognosis. If there is a defect in IZ zone, intermediate zone, it's a bad prognosis. If they involve the both EZ and IZ, is grade 3, poor prognostic outcome. And if it develops the external limiting membrane break, then it's further loss of vision. The grade 3 and grade 4. Grade 3 where the loss of reflection of IZ and EZ, and grade 4 where the loss of reflection in IZ, EZ and ELM. These are not reversible. Now surgical intervention of the traumatic macular hole, when to operate. If there is no cystic fluid here in the left side, then this hole is not going to do well with surgical intervention. Only observation will do well, it will close in future. But if it is associated with partial parafoveal cystic fluid in the retinal layer, then it will do well with the surgery. This is traumatic macular hole with retinal detachment. Is after surgery, it will close, but it can lead to foveal atrophy. Thank you for patience hearing.
Thank you, Dr. Krishnendu. So because we are going to discuss the macula, I'll present surgical scenarios also, and then we'll have the words from sir and other questions. This is the last topic of the session. So, period was stable or regressed in more than 60% of people. And in a study by Q and Liu, 21% of the eyes required surgery, only 21% in 4 years required surgery. So they had their own indications for surgery. So what are the indications? Most of the times, if the visual acuity is less than 612, because better than that, a patient may have some improvement in metamorphopsia. If the patient is very symptomatic about metamorphopsia, then you may operate. Otherwise, better not to touch those eyes if the patient is not symptomatic. Just because you are seeing an ERM, better not to operate. Any recent vision loss complained by the patient? Definitely yes. And grade 2 ERMs, definitely gas grading as classically described in the textbooks. I took these images from the textbook only. So grade 2 epiretinal membranes are definitely indicated for surgery. In that also, you just look at the requirement of the patient, especially this the more than 80 years of age group. And on OCT, look for either a diffuse adhesion or a focal multiple adhesions. Most of the secondary membranes are like, they show focal multiple adhesions. And points to look for are like central foveal thickness, disruption of the photoreceptor inner segment, outer segment junction, and ectopic inner foveal layer, VMT, lamellar macular hole. Lamellar macular hole has a poor prognosis compared to a pseudo hole. There is a definite confusion between LMH and pseudo hole. So if you look at this particular thing, this is a pseudo hole, and this where there is loss of retinal tissue because of the rupture of the cystic spaces, that is actually a lamellar macular hole, but they are used interchangeably. And any vitelliform lesion, and the disorganized disorganized outer retinal layers, they carry the poorer prognosis. So these are the things which we look for in OCT. And during surgery, definitely look for absence of PVD, especially from the disc. There may be, because PVD is a prerequisite, at least partial PVD is a prerequisite for ERM formation. So still there may be vitreous attached to the disc, so PVD induction is a must. You should not miss that. And staining for removal of the membranes and ILM peeling supposedly adds to prevent the recurrences. And definitely look for peripheral lesions or breaks to prevent the complications. So worst outcome is with those who present with poor visual acuity. But if the patient is coming with 660, they may improve up to 618 only, they may not go to 66. But the more lines of improvement are seen with poor visual acuity. So they have better quality of life when you are looking at the quality of life. So this is what the literature says. And longer duration of symptoms, definitely worse outcome. And the visual acuity improvement is not immediate. One should impress upon the patient when they are counseling for it, because 2 to 3 line improvement in 75% of patients happens over a period of 6 to 12 months after removal of the epiretinal membrane. So definitely combined cataracts VR surgery adds to the better prognosis, and complications reduce it. If you look at this, small preretinal hemorrhages may not matter much, but you may see vitreous hemorrhage which is not clearing, and subretinal hemorrhages also may happen if you have torn the retina while peeling the ERM, cataract, and retinal breaks, the extrafoveal macular holes also do happen. Retinal detachment and recurrence is only 20% around 2 years in most of the studies. More common with young patients. And ILM peeling, as I already said, ILM peeling and use of some steroids, intravitreal steroids, supposedly reduces the chances. So coming to the full thickness macular hole, it has lot of discussions and many classifications. You can look at this table. The textbook only is quoting this table, and there are, if you go to the literature, there are many people have given their own kind of classifications and grading systems and other things. So macular hole is most discussed thing, especially in terms of prognosis and the results. So stage 1 holes, if you look at the studies, 29% remained stable for 1 year, 48% regressed. So this is almost like a higher side of the VMT. So 48% definitely regress. So stage 1, better not to think about. And stage 2, definitely they progress. So from stage 2 onwards, you have to consider surgery. And stage 3 and 4, they rarely close. So one study showed that followed up for 5 years and none of them closed. So OCT, though there are many parameters, many calculations, many formulae that were derived, as on today, most of the literature says that minimum hole width is the one which we are looking at to prognosticate. And there are many things like hole diameter, as already mentioned, and defects, and also intraretinal cystic changes, epiretinal proliferation. Definitely epiretinal proliferation, which we usually encounter when we do the surgery, it definitely reduces the prognosis. And like there are many papers which predict that lower the gauge, the better the prognosis, and many things are there. ILM peeling with or without staining, and extent of ILM peeling. And yeah, definitely they say larger the hole, larger the extent of ILM peeling. ILM flap also, pedicle flap or free flap or temporal flap, drape it or stuff it, lot many variations are there. And whether to cover the hole or the fill the hole with some other material other than the ILM, there are lot many things including the smile lenticule also have been described. And relaxing retinotomy is also described to let the hole close and form another hole on the other side. So tamponade, there is a lot of discussion regarding that also. Nil positioning, avoid after the tamponade and even positioning also. Avoid supine is one concept, only for 1 to 2 days is one concept, only for 5 to 7 days. Lot many literature is available. But if you look at the meta-analysis thing, this is just published this month, and they say that pars plana vitrectomy with or without internal limiting membrane peel for macular hole, they found that almost similar visual outcomes in the end. Almost similar, but definitely macular hole closure increases in larger holes. That's what they want to say. And in this meta-analysis also, they say less than 400 microns holes. So there are like lot many meta-analysis also. I could find at least 40 meta-analysis only regarding macular hole when I search for the literature. So I didn't name this title as guidelines or recommendations. I just want to name that as currently widely accepted points. ILM peeling for all holes, more than 90% success rate compared to 50% success only in no ILM peel eyes. So, if at all your hole is not closing, if the hole diameter is less than 400 microns, if they say it should be 100%. So, if your surgery is not giving that result, then reconsider your surgical technique. That's what I would like to say, because the literature is saying that it is the highest success rate if you do ILM peeling in less than 400 microns. And ILM flap, better for larger holes, cover the hole and do not stuff. Other material is for resurgeries, and definitely till it closes, hole needs to be protected from fluid in vitreous. So prone positioning does help, and choose tamponade accordingly. And complications, there are many this thing, but reopening of holes was described in pre-ILM peeling era. More common with larger holes, and it was 7% in pre-ILM peeling era. Macular traction, I have only another 4 slides. So, study of the natural history says that, spontaneous resolution happens in 20% over 18 months, and it is stable in 60%, and vision is also stable. So, you can always discuss with the patient what they want and what exactly they are feeling. And full thickness macular hole may happen in 12% and ARM in 20%. So, this is a case where I waited for a month, and the VMT got relieved. The patient is one-eyed, came back, he was under my follow-up only, came back with drop in vision 612, he was previously 6.6. Then when I saw the OCT, it was VMT, I didn't immediately go for it. Then when I waited for a month, that got relieved, and 6.6 came back. So one should wait whenever you are seeing acute VMT. And poor prognosis, if it is a broad-based attachment, cystic spaces beyond the area of adhesion is most important. And if it is associated with epiretinal membrane, then also a poor prognosis. And treatment outcomes, they say visual acuity improvement happens only in 65% even if you operate. And complications are seen in 20%. And pharmacological vitreolysis was not encouraging, and it showed more significant changes on ERG. So that ochriplasmin was not widely accepted. Gas injection, somehow it has not gained importance, but it relieved in 50% patients in 1 to 3 months. So inject something into the either saline or gas. Gas was preferred, but I think this needs exploration for VMT cases if at all they want to treat. Coming to the submacular hemorrhage, this was one patient with trauma who improved without any intervention from 660 to 618 in 1 month, and 6.6 in another 1 year. And he maintained for 10 years like this. And this is a AMD with large submacular hemorrhage, only anti-VEGF treatment, and the disciform scar at the macula prompted me not to go for any gas injection. And then she got the clearance of the hemorrhage. So what is the natural course? Best prognosis without treatment in post-trauma young patients, but poor prognosis if it is associated with AMD. The problem is that we don't know what are the criteria to intervene. There are many people who intervene even for a smallest hemorrhage. There are many people who doesn't intervene even for largest hemorrhage. So till date, there are no established criteria regarding size, thickness and duration to determine the prognosis for this, whether to wait or to treat. there are multiple combinations. As on today, the literature says it is surgeon's choice. There is no recommendation what to go for and which situation. It is all, as on today, everyone is doing by their choice. So this patient, which was treated only with TPA and anti-VEGF and gas injection, cleared in a day. So thank you. Sir.
Let me just keep it brief. Dr. Krishnendu as well as Dr. Rama have covered almost all the prognostic factors. Some factors, as far as the AMD is concerned, despite the treatment, there is a significant number of patients will continue to lose vision. So the 7-up study showed that nearly about 1/3 of the patient will decline, about like half of them may remain stable. So that's something which we need to remember despite whatever we do. Another factor which I battle with is the occurrence of geographic atrophy when we start giving the anti-VEGF. So there comes a stage when there is significant amount of geographic atrophy. In addition, the patient has exudative activity. And if we give further anti-VEGF, whether the geographic atrophy gets worse. So that's a concern. So there I kind of balance between closely following up the patient to see if there is one line loss or if there is edema worsening as compared to the last visit, then I give an injection. Otherwise, I don't try to make the macula dry. So that's something which I battle with. So that's another thing which we have to look out for. Though we can prognosticate, say, yes, of course, there is obvious vacuolation or outer retinal tubules. You know that this patient is not going to do well in the long run. But if you're seeing the patient for the first time, I would still inject to see if the patient improves by 1 line, 2 lines, and then decide about continuing the treatment or not. But more importantly now for prognosticating to see whether we have to inject at that point in time or not is where we have to look at the geographic atrophy which is occurring as we continue to give the injection. As far as CSC is concerned, if it's a middle-aged patient around 40, 45, 50 with a CSC, then we need to look at the pachychoroid disease. So that would indicate that look at it more carefully to see if there is a pachychoroid disease which is mimicking a CSC or if it is a CSC. That will help us decide on the prognosis and also to see if in case he has to be followed up closely for the other eye disease development. And myopic maculopathy, the moment the patient comes, we don't jump in and operate, though the OCT may look scary. If there is a recent loss of vision because of full thickness macular hole and a macular detachment, yes, we operate. But if it is just a tractional schisis and the patient has come for a routine checkup with a slow loss in vision, no harm in waiting for a month or to see if in case there is a progression of the myopic maculopathy and then decide on the treatment, because sometimes this can remain stable. Vitreomacular interface disorders, it's very tempting to jump in and operate, but studies have shown that many of them remain stable. Nearly about 75-80% of them remain stable over the next 3 to 4 years. So there is no need to jump in and operate, particularly if they are asymptomatic. If they are symptomatic and progressive loss in vision, then we jump in and operate. Otherwise, VMT can be watched as well. In fact, I have my own sister-in-law who had a myopic traction maculopathy whom I operated. She improved from 624 or 636 to 66. But she is absolutely unhappy because she has metamorphopsia. On one side, she is saying gross metamorphopsia, which was probably obscured by the fact that she had poor vision before. Now that her vision has improved, now she is noticing it, and she is saying that I cannot use my better eye as well. Not that better eye is better. Better eye also, she's got a VMT with inner layer hole. But then now, though her vision is 6.6, she's absolutely unhappy. I'm unable to help her in any way. Now it's 1.5 years, 2 years, and recently she had cataract, and cataract made it even worse. When she had the cataract, she was not able to see it that time. Now the cataract surgery is done, it's even worse. She is absolutely miserable. So that's something which we have no answer about. So consider carefully before you do the surgery. And you can always consider that it's my sister-in-law. So most stress.
Yeah, one should consider these factors before deciding a surgery, definitely.
That's why I'm not touching her other eye. A subretinal hemorrhage, yes, there are some indications to say that subretinal surgery is not required for all subretinal hemorrhages. There are recently at least 2 papers which say that intravitreal TPA with intravitreal gas is as good as doing a vitrectomy with subretinal gas and subretinal TPA. I would do vitrectomy now only if there is a breakthrough vitreous hemorrhage and that we are not able to see the macula. Otherwise, intravitreal TPA with gas is as good as not doing a vitrectomy.
Thank you, sir. Anybody has any question to discuss? Because this is the last session, we don't have any other session after this, we are going for GBM. So the audio visual people are looking for us to conclude the session. Anybody has any question? Otherwise, we'll call it a day and we'll wind up the session.
But I think we're pretty much on time. I think we're given about 15 minutes late and we finished.
Yes, sir.
Yeah.
Thank you. Thank you all. We'd like to have a photo